day. So let me, if I can, share my screen, and we'll get right to work. And my last one first. So this here. And so as Sydney explained to you already, I am the chair and one of the founders of the Buffalo Center for Health Equity. And we have been working as an institute, as an organization, probably about 2 or 3 years. And that was birthed out of the African American Health Disparities Task Force, and which has now evolved to a more aspirational title, the African American Health Equity Task Force. And as you see there, that's just me again. And to give you a sense of some of the things that, again, Sydney already explained those things, that I'm currently the chair of the center. I'm chair of the task force, chair of the Research Institute's Advisory Council, and I'm on a number of other places where I have an opportunity to serve this community. When you have any questions or about the work that we're doing, I would invite you to go to the buffalohealthequity.org website, buffalohealthequity.org, and that will allow for you to engage with us via the internet. I want to start our conversation, kind of frame it, talk a little bit at first about the level of the issue. I know that the health equity has been a buzzword probably since the emergence of the pandemic. But for some of us, we have been working on these issues around health disparities and health equity for a long, long time. And it's been something that has really been a part of the struggle for us as African people, people of African descent living here in America. And I wanted to kind of frame it in the context of one of the great leaders and freedom fighters that we've had in this country, Fannie Lou Hamer, who famously said, "We are sick and tired of being sick and tired." And really, that's kind of where we are for a lot of us in the African American community. There's a great book out called Black Fatigue that lifts up just some of the realities that Black people in America have to deal with and face each and every day. And then the outcomes of them will produce some very horrific health outcomes. For example, and I have a couple slides that kind of lift these things up, that we are 44% more likely to die of strokes, Black people. And the HIV and AIDS crisis was something that we don't talk a lot about now because the numbers have kind of gone down in many communities. But Black women represent 66% of the new HIV and AIDS cases in this country, and Black folks are 8 times more likely to die. 9 times more likely to die than whites from HIV. High blood pressure, hypertension. That's when you go to the doctor, one of the first thing they do is check your blood pressure. Well, again, Black men are 30% more likely. And what's alarming is our sisters, Black women, are 60% more likely to be diagnosed with high blood pressure. And these are comparisons to white Americans. Cancer. Black women are 52% more likely to die from cervical cancer, and 40% more likely to die of breast cancer than white women. Even though white women are more likely to get breast cancer, African American women are more likely to die. Black women are 243% more likely to die from pregnancy and childbirth related cases. Black people are 25% more likely to die from heart disease. And then when you see these numbers, or you see these on a different charts, it's a bottom line. It's a life or death issue, right? I mean, it's not hyperbole. Many of us who are doing this work, this is not rhetoric. This is not something that, kind of a scheme in order for Black people to get some money or what have you, or it's not like we are exaggerating things. I mean, the numbers, and one of the things that as we talked this afternoon, I want us to begin to start engaging this conversation from a more intellectual and scientific perspective and less emotion. Our emotions should drive us to wanting to getting engaged, but we have to understand the data, the facts of the matter in order to develop real meaningful responses to this crisis. Going back to the maternal health thing, you know, one of the things about language is so important. We have to liberate ourselves from a lot of catchphrases in language that are really, in a lot of ways, not representative of the reality of what people are facing for. So when you think about, you know, the issue of people calling themselves being right to life or pro-choice. Well, and I guess that's important for some people to claim those things, but really it kind of has reduced itself to a conversation about, you know, really a right to give birth or not to give birth, right? Or, but when we're talking about things about right to life, you know, and the right to live, I think everybody should be concerned about that. But we see that the issue as it relates to maternal health, and especially for Black women, goes far beyond the decisions and choices about terminations of pregnancies or not, right? It's a much more nuanced, much more important issue when we start talking about people's ability to have children and have those children safely and to be able to care for those children. And so when you look at Black women in America here today, mortality ratios are 3.2 times higher for Black women than white women. And you see here the two largest groups. They do these by 100,000 births. Look at the numbers, the comparison numbers, the two ones in the green for Black women, and then the second one, the indigenous community and Alaska Natives. But then when you look at the comparison data between the total, the 16.7 versus 40.8, and then when you look down to white women, the disparity is really, really dramatic. Almost 41 to 13 type of a ratio. And these are facts. These are not things that, you know, these are not liberal facts or conservative facts. They're not, you know, they're numbers. They're just numbers. And this slide it's a great slide. I mean, it's a great diagram. It's hard to read. It's kind of small. But again, I want to just lift up a couple things on there. You know, we already talked about the stroke numbers. 44% more likely to die of a stroke. African Americans are 20% more likely to have asthma. And three times more likely to die from asthma. And that's very important when you start talking about respiratory diseases. And that became very apparent during the COVID-19 outbreak, where you see that heart disease, diabetes, and asthma were three pre-existing conditions that made people very vulnerable to COVID-19. Well, in the African-American community, those three areas, there's such huge disparity around African-Americans having such diseases and whites. African-Americans are 25% more likely to have heart disease, 52% more likely to die of cervical cancer. Black men, twice as likely to die from prostate cancer than our white brothers. The death rate for African-American women, again, 3 times more likely. 3 times, a Black woman is 3 times more likely to die giving birth than a white woman. And that goes beyond some will say, well, that's related to education and resources. And that's a partial fact. There's no question of that. But when you dig deeper into the data, we find that African-American women with college educations still have worse birth outcomes than white women without college education. So it's really deep. And then one of the numbers that are really is alarming. Well, they're all alarming, but diabetes is the crisis around diabetes is just incredible. African Americans are 72% more likely to have diabetes than whites. 72%. And again, there's so many other health factors that contribute to having diabetes, and there's so many poor health outcomes that are attributed to diabetes as well. And what's interesting, those who are medical in the medical profession will tell you that oftentimes African Americans do not present with just one of these ailments, right? It could be, asthma and heart disease, or a pregnant woman with, issues as it relates to obesity and diabetes. I mean, and so a lot of times these factors, they build upon each other to really create some really frightening health statistics. One of the things that we're seeing is not only these health disparities, we don't only see in the physical realm, but in the mental realm. We are seeing just a proliferation of African Americans with mental health challenges as well, even to the point where African American children, youth that are in high school, are 61% more likely to attempt suicide than white children. 61%. And so the crisis around health is both physical, mental. It's both for our in pediatrics, maternal, male, female. It's a crisis that is just exploding throughout the entire African American community. One of the outcomes, again, we've seen from COVID is that COVID has shaved about a year off of life expectancy for whites, but 3 years off of it for Blacks, and we were already starting 8 to 10 years below the life expectancies for whites. So why is this happening? Well, we would argue that, and most legitimate health organizations, public health organizations, institutions that look at these kinds of things will clearly contribute this to the issues around the social determinants of health. And those would be the complex, integrated, and overlapping social structures and economic systems that are responsible for most health inequities. And so most of the data shows that these kind of social determinants of health factors really contribute to about 60 or 70%, some studies have shown up to 80% of the impact upon your health. And even when you think about your own behaviors, though, when people say, well, there's certain behavioral things that people can do in order to better impact their health, and that's absolutely true. But a lot of those behaviors are also influenced by the social environment, the lived environment in which that individual lives. And so these social structures and economic systems include the social environment, physical environment, health services, and structural and societal factors. Social determinants of health are shaped by the distribution of money, power, and resources. Very important point there. Shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. Well, in the United States of America, in this republic, when people of African descent were first brought here into this part of the world, 1519 in South and Central America, 1619 up in beginning into North America, and brought into this region, kidnapped, stolen, having our identities stripped from us, our connections to our theology or our spiritual way of living, our family structure, the raping of our women and even men, young boys. It's documented. And the whole economic system of this country was really built on the enslavement of African people. The first commodities in this republic were Black bodies. There was laws written to regulate the movement of Black people and to legalize the ownership of other human beings far before the Constitution or the Declaration of Independence was even written. And so this type of dehumanization of people of African descent in this region has had generational impacts that impact the distribution of money, power, and resources that is available to people of African descent. And so another way of looking at this social determinants of health is in seeing those different factors: economic stability, neighborhood. Dr. Henry Taylor talks very eloquently and has written prolifically about the impact of neighborhoods and housing upon the health and the structural and systemic racism that has been in housing policy in this country and continues to be in this country, that has a negative impact upon the quality of life. And that's what we're talking about today, the health outcomes of people of African descent. Education. Recently, if you saw some of the reporting that came out of Investigative Post and on Channel 2, looking at the literacy scores in the city of Buffalo, where most Black children go to school, and drilling down in the data and finding that even in some schools where our Black children are going to schools, back to school today, where there's no child in the whole school was at grade level for literacy. And that's not the child's fault. That's a system. That's a system that produces those kinds of outcomes. And then the food, when we saw the massacre on May 14th and the shuttering of Top Supermarket, which created a food crisis, that it made it necessary for organizations like the Central Kitchen that provides foods in war-torn areas or places where there's disasters and floods in the third world to come and have to set up camp right on Jefferson Avenue in our city, in a first world nation, and a city that claims to be under a renaissance, right? A city that has money available for billionaires to like Elon Musk with that Tesla fiasco, and then recently the releasing or the providing of $850 million for the Pagulas, for the building of a new stadium, right? And so these types of resources, a same city that has Buffalo billions and things of that nature, how can there be how can there be an access to food crisis that comes to such a level that you have to have emergency relief organizations parked in communities distributing food? That's a tremendous indictment upon the infrastructure of a community. And then and you see all these factors that you see there, they're all impacted by structural and systemic racism, institutional racism. And so and so we have to, again, as we start talking about labels and things like that, we cannot be afraid to name that. And by naming it, we're not saying, sometimes people hear that when they say, okay, when you talk about systemic and structural racism, you're saying all white people are bad. That's not, that just shows a complete lack of listening skills, quite frankly, or an inability to be open to look at the reality of a situation in an intellectual, from an intellectual perspective, right? And so in order to because we really want to get to the point of health equity. I think that's what we want to do. I know that's what I'm dedicated to and the partners that we work with. Well, you can't get to that point until you have an open and honest and transparent conversation about what are the driving factors to the problem, right? In order to save a problem, to solve a problem, you got to understand the source of the problem, right? If you were fixing a hole in the roof, you got to understand where the origins of that is. You just can't just act like it doesn't exist, right? And so you really have to have the kind of conversation that's necessary to really tackle this problem. One of the things that you look at is when you talk about the social determinants of health and living in a first world capitalist country, the access to wealth is a great indicator upon the quality of life for a community, all right? And remember, the wealth accumulation in this country is directly tied to the free labor of people of African descent that labored for free from 1619 up into the late 1800s. And then even after emancipation, Black men were arrested on what they call the Black codes and on violations of vagrancy in prison, in Southern prisons, in Alabama and other Southern states, and then sold, their labor was sold in coal mines and in steel mills, right? Way before unionization of that type of labor. And so there was also free labor that also contributed to not only the funding of the Industrial Revolution, which made America, or the American experiment, it made it economically feasible for these colonies to become an economic player on the world stage through the transportation or exportation of cotton, tobacco, and sugar over to Europe. And then the tremendous amount of wealth that was generated from that, not only in the South through the plantations, but also through the North through banking systems and insurance and shipbuilding, which created an economic model that was able to fund the Industrial Revolution, and then from the industrialization, which really made America a player on the world stage in terms of becoming an economic superpower. All of that happens because of the free labor, right, that was done by people of African descent for hundreds of years, right? Not 5 years, 10 years, 20 years, but a period from 1619 up and through the late 1800s. And so what happened is that the wealth that was generated in the country was not equally distributed to those who actually labored for the wealth, right? And so you see here a good chart that shows I was born in 1963. And so we see during my lifetime, right? So we're not going all the way back to grandmama and then. I'm talking about my lifetime. Now, I could be a grandparent to probably some of you on this call, but the distribution of wealth, right, between whites and Blacks is still at a level, and in some ways worse in some ways when you look at the real value of money, than it was when I was born. And so these are things that have an absolute impact upon the health outcomes in a community. So here's where we want to get to, because I want to make sure that we have enough time to talk about how do we solve these problems. But I think it's very important to frame them, because a lot of people don't really know this stuff, right? And a lot of people that are in positions to influence policy don't really understand this thing. So if you look at this chart and look at how the arrows are going, and we want to start with accepting the fact that these inequalities exist, right? We can no longer waste time with having conversations about whether or not there are health disparities in America, right? That's just, that's like, arguing whether water is wet. We have to accept that is a fact. The data is showing that. Two, we must understand, and you see, we're going to go in that kind of a circle here. And then when we understand it, we have to understand the historical and current reasons for it, why it occurs, right? So we can no longer point our finger and blame Black people for, y'all don't exercise, you eat the wrong foods and all that other stuff. Well, those things may be a factor, but we might be true at some level, but we have to understand why that is happening, right? And when we have to, and that what brings us to the root causes. We have to shift from a charitable model to a systems change model, right? We cannot build a system large enough to provide a service delivery system large enough to address the needs of all people who need the services. It is smarter to understand why people, in particular, we're talking about people in the African-American community, need all these services, and then try to address those root causes that are driving the reason why we have these health outcomes. And we're going to talk a little bit about that in a little more detail. And then we have to build a broad-based coalition that can solve the problem, right? It cannot be, these problems cannot be solved by activists, community-based organizations, preachers, or whoever. We have to have a broad-based coalition of influencers that include government, corporate America, philanthropy, institutions like the University of Buffalo, and block clubs, grassroots organizations, community-based organization. It's going to create that kind of require that kind of a table to really, because what we're talking about, I hope you understand that we're talking about a problem that has been in existence since people of African descent have been in this country. So it's generational. It's not episodic, it's generational. So it's going to take a real comprehensive response if we want to get to the goal of health equity. Then we have to make health equity a community priority, not just a Black community priority. It has to be a way in which we measure our success, the success or the quality of the community in which we live, right? We can no longer measure the quality of Buffalo, New York, but whether or not the Buffalo Bills win a football game. Right? We want to measure those, make the Buffalo's a city of good neighbors. Buffalo's a great place to live because we have addressed the issues around the inequalities, race-based inequalities in our community. And in order to do that, we must invest the necessary resources, right? Again, going back to the examples, you know, where when government or when communities make something a priority, right? They invest the resources in order to influence the outcome, right? So you can't say something is a priority in this region and then you don't invest the necessary resources in order to solve the problem, right? We don't even know what those resources are because we haven't really done the work to really dig deep enough into these issues to know what it's really going to take to bring us to where we want to go. But we must make a commitment, whatever that number comes up to be, whatever it is, we got to be committed to finding a way to make that kind of investment. And then going around, then we have to monitor and evaluate it, right? We have to, whatever process, whatever systems change, whatever kind of initiative we embark on as a community, we have to make sure that we keep close eyes on it and evaluate its success during the process, not so that we can dismantle it, but so that we can make adjustments, right? It's like, you know, we don't have to look and watch something just fail for 10 to 15 years. And at the end of those 15 years, you know, wag our fingers and say, see, I told you this wouldn't work, right? And so we have to, all throughout the process, we have to monitor and evaluate whether or not we are achieving the things that we say we want to achieve. I want to get back to this thing where it's make health equity a community priority. Mahatma Gandhi said this: action expresses priorities. So the fact now that you hear the buzz around health equity, DEI, all these other things, these kind of catchphrases that are going on, I think it's a good thing. I think it's a good initial step, but I've not seen the evidence yet of the kind of broad-based action that would make me to believe, and my colleagues to believe, that Western New York health equity is a priority for this region. I think the conversation is getting better. I think we're beginning to look deeper into things, but I think that the scope of the response from community has not risen to the level of the size of the problem. And so we got to continue to work on that. So whenever systems say there's no money, they're lying. So the massive wealth in the United States of America, right, means that any problem, anything that America wants to make a priority, and wants to address, wants to deal with, right? The lack of money will never be the reason why it doesn't happen, right? It's just a matter of how we prioritize or how we want to spend our money. So clearly, this gives you this. I want to give you a kind of a snapshot, right? So America today spends. Look at that disparity there, right? And look at that distribution of resources. So when we say that we don't have money to provide a child care for working mothers, or we don't have money for to provide services and quality affordable housing for our seniors, when we say we don't have money to develop a transportation system that allows for working people to get to a job that will pay them a living wage, because we don't have the money, that's a lie. I need to be very clear about it. That's an absolute lie. We have the money. It's just a matter of whether or not we want to spend the money on those things. So you look at how this country spends our money, and it's more than the next 9 countries, right? So there's all this conversation about Russia now, and how much Russia's. Look at the size of Russia's military budget compared to ours, compared to China and Russia's combined. And so the resources are there, and it's not a Republican Democrat thing. It's not a conservative or liberal thing. That's what. And I urge you, if you don't get anything from this talk, just do the research, read, find, go and if you don't agree with anything I say, go look it up and challenge it, and make your own decisions and understand what's going on here, right? So this is the Biden administration, the ones that claim that, the ones that others will claim is weakening our military and liberal policies and all this other crazy. It's all lies. It's all lies, my friends. That you see the amount of resources, right? And that what we spend on the military is about the same as what we spend on everything else. Everything else combined in this country. So and again, when we talk about priorities and investments, the dollars are there. So what are we doing here at the Buffalo Center for Health Equity? We're operating from a model of 5 important pillars. 1, research. You got to understand the data. The data helps inform policy, and the policies help bring resources. So when we make these arguments about health disparities and asthma and all these other things, we're going to have the data, and the data is readily available. It's there. We just got to do the work. And now we're in this region because of our influence. We have the University of Buffalo. We have the County of Erie. We have Population Health Collaborative has merged with Healthy Link, and Healthy Link has centered now as part of their mission to look at issues around health equity. So now we will have all the data that we need, right? And then we want to talk about, we're going to focus on policy development, right? Policy impacts everything in our daily lives, right? So how do we create public policy that will have a positive impact upon health outcomes? And then you have neighborhood development, and we're working with our partners through Dr. Henry Taylor's office, through LISC, because we're all about building bridges and building coalitions. We cannot do this work on our own, that we have to destroy this notion of my organization is going to do this, that, and the other. No, we have to work in collaboration, because all of us have different gifts, skills, and resources that we bring to the table. You cannot you cannot enhance the life of a child without enhancing their family, and you can't enhance the life of that family without enhancing their neighborhood, right? And so they're all interconnected. We learned from the blizzard, right? That of the 50 or so, I think of the 40 or so people that we lost during the blizzard, 20 of them came out of the East Side or the African-American community. Why is that? It's because of some of the reasons is access to housing, lack of money, quality of housing, all these factors. So neighborhood development is critical. And then advocacy, right? Working with community. Government plays a big part of our role, whether you like it or not, that's the reality. And so how do we make government to be more responsive and more sensitive to the needs of those in our communities, right? And then community engagement. We firmly believe that the people on the ground level understand their needs, and they understand how the system can better serve them, and they can understand better how institutions can be better partners with them. So really spending a lot of our resources and time working with the National Witness Project is another one of our partners, working with Erie County. Shout out to Kelly Wolford, the director of the Health Equity Office in the county. And if you have not read the Health Equity Report from the county, please do so. It's a great document, and it gives us some direction. I'm going to skip this and go, because I want to give you time for some questions. So here are 7 things that I think we need to focus on. 1, closing the wealth gap, right? And then we'll fill in under this. So you make these kind of broad statements and then figure out how do we do it. So we need to close the wealth gap. We need to make sure public spending projects they're implemented through a health equity lens, right? So for example, I'll go back to the example of the football stadium. So if this region's going to spend, let's say $1 billion, 850 billion, split the difference, right? $1 billion. How is that investment going to impact the health equity or impact the communities where they have some of the poorest health outcomes? Improved housing in the region. And I agree, and Dr. Taylor has said this very clearly, we can't build ourselves out of this, right? There are people right now who are living in substandard housing that need an investment or some help to remodel, refurbish, rehab, weatherize their homes, right? And so, because they may not want to move, right? But they may not also have the resources to do the necessary rehab to make their homes healthier. Inadequate housing impacts asthma. And again, all these things are documented. Food is medicine. Rita Hubbard Robertson and that team, and Allison Dehoney and Alex Wright and Rebecca Williams and all of our other partners who have been doing some just tremendous work on trying to get access for healthy food for people in our community. We use the term food apartheid and not food desert. A desert is a natural phenomena, right? It's created by nature or what have you. Now there are human behaviors that are beginning to create deserts from pollution, but the reason why we don't have access to food in our communities is because of food apartheid, because of policy decisions that have been made in the public and private sector, right, to limit the access of healthy food in certain communities. We got to close the educational opportunity gap, right? We have to understand and look at these educational outcomes, because again, with if these children are not put in position where they can excel academically, and we're now living in a technological age, their capacity to get high-paying jobs is going to be extremely limited. And we're almost creating a permanent underclass by allowing so many of our young people to not be able to matriculate in the educational system. Not saying that everyone needs to go to college, but even to get into some of these training programs like the Northland Training Center, you have to be able to have mastery over certain levels of mathematics and English and other things that you need to be able to do. You should have that when you get your high school diploma, but we're learning that there are many people, young people from the African American community that even with their high school diplomas still have not been able to pass the TAFE test or do other basic skills. And again, it's not their fault. It's a system that creates this kind of acceptance of mediocrity, and not putting in the requisite support systems in and outside the educational system to make sure that those children have a world-class education. Environmental justice. I forgot I forgot her name, but a professor at the University of Buffalo just recently was awarded a grant that she began to look at temperatures and air quality and water qualities in the Black community. And I remember the day she called me and she was just doing some preliminary stuff. And she was appalled at just the huge disparities around air and water quality and the actual temperature on the east side of Buffalo, where most Black people live, and she's going to be doing a robust study. So, the air and water quality is a real issue. And then we have to look at violence and view violence as a public health issue, right? The violence that is so pervasive in our communities is creating a health crisis, and we have to respond to it in a holistic way and not in a punitive way. So I'm going to stop there and give us some opportunities to have some conversations about things. Don't ask me questions, expect me to give you like an exact answer. This is not this is social science, right? So it's not like 1 + 1 = 2. It's a process that we must put together and begin to look at how the things that we need to do in our community, what needs to be done, right? And we have to be willing to take some chances and risk and say, well, we'll try this and maybe it works, maybe it doesn't work, I don't know. But this one thing we do know, I think if we look at this intellectually, we can say without equivocation that what we are doing now is not working. I think that's beyond debate. And if you still want to debate that, I can't help you in that space. But if we have to start with the conclusion that what we have is completely unacceptable, but we also have the power and the influence and the capacity to change it. The question is not whether or not we have the desire to do so. So Nadine and Sydney, I'll pass it back over to you, and because we have a few more minutes, right? That we can have for questions. Thank you so much. Again, I'm filled with immense gratitude. You guys had a choice to spend this time with us, and I thank you for making that choice to spend some time with us today.
Thank you, Pastor. I don't know about anybody else in here, but I definitely learned a lot just from that presentation. So definitely gives me a lot to think about. I don't know if anybody else is feeling that same way, but I certainly hope so. If anybody does have any questions, you can either put them in the chat, we can read them out that way. I invite you to use the raise hand feature as well, if you would like to unmute yourself and ask that way as well.
Yeah, hey Pat, thank you for that question. So we've been engaging with the philanthropic community with getting them to begin to look at more systems change type of funding. So I will say that the philanthropic community in Buffalo is extremely generous in the context of charity and services, right? So, I think they'll step up when there's, some service stuff and charity stuff. And that's good. It's good. But we have to get the philanthropic community to be more engaged and funding problem solving, right? To funding the kind of intellectual study and policy recommendation and things of that nature that could maybe impact the problem that we're always having to throw money at because of the negative outcomes that the broken system has created. And I will say the Western New York Health Foundation has been very progressive to date in helping. They've funded some of the work that we're doing, and we appreciate that. And I have a feeling, I have a sense from some of the other foundations that some of the other ones, others not so much, but some of the other ones, that they're beginning to listen, because they're seeing, Pat and the rest of you, that the good money that they put towards a lot of stuff over the years hasn't really moved the needle, right? And again, that's no fault. It's not a criticism of all the people who have worked really hard on trying to help people. But sometimes it's just, if you're not dealing with the root causes, right, it just seems like it just keeps coming at you. Does that make sense? Does that answer your question, Pat? All right, thanks for asking it. Let's see, who else do we have here? Sophia, how may we collaborate with you on these initiatives? So please go onto our website, buffalohealthequity.org, and look at some of the stuff we're doing every third or fourth Thursday for the last 6 or 7 years. We've been having a health disparity, African-American health disparities task force meeting. You're free to come be part of that. You can reach out to us. Sophia, send us a note, and we'll connect with you, and we can figure out a way which we can get you plugged in to some of the work that we're doing. Yeah, and Samantha Hidalgo, a number of our staff are here helping populate the room. And so if you look at Sophia, if you look on there and see Samantha Hidalgo's on the chat, reach out to her and we'll get you plugged in. Antonio, it's good to hear from you again. Trauma informed is, oh man. How are you addressing trauma on the east side of Buffalo? Wow, that's a big question. So we have a mental health component of our work, and we've been working with Carl Shallahorn and Kelly Wolfer was on that team, Kelly Lucci, Aaron Moss, a number of people. And so we have a mental health component of stuff that we're trying to work on, but we're really and trauma really impacts all the work that's been going on. And so we can get you plugged into some of that work, or if you have some ideas on some things that we can engage in, we're open to doing that. Again, we're a think tank. We're not someone corrected me on, we are delivering a service, but we're not in a traditional service delivery system in terms of case managers and all that other stuff. But we're really trying to build bridges and coalitions and bring people together to kind of come up with some macro level systems change ideas. But we also do support with direct funding to a couple of smaller agencies that are doing some really terrific work in the community, and we want to support them in their work. So I hope that answers your question, Antonio. But I know you, and I'm sure if I have it, I'm sure you'll ask. You'll get to me, and we'll straighten it out. Any other questions? Nobody has questions.
I'll ask another question, and that is, since this group has been involved, and because a lot of us here are social workers, we're interested in the dynamics, like getting it up and going, and any conflicts, and that could include within something looking at racial health disparities, racial tensions within that group.
Well, I mean, the racial tensions, what do you mean? In what context? Yeah.
Are white people taking and assuming decision-making that perhaps they shouldn't?
Yeah, so when we build the kind of cross ethnicity coalitions that are centered around solving problems in the Black community, our white partners have to be willing to be led and not be leaders. And that is a problem. It's a challenge just because of socialization, right? That it's very difficult, I think, for many of our white allies to come to the table in such an open way that, and a willingness to follow Black leadership and to not interject their feelings in the process, to the point where their feelings can sometimes suck oxygen out of the room, right? So a person's willingness to show up and be present is, you don't have to qualify that when you come, right? You don't have to, well, here's why I'm interested in health equity, and give a long soliloquy about your journey with your racial awakening. There might be time for that, right? But when we're trying to have work done, right, we don't have time for that right now, right? And so we got to have that kind of the conversation, and also understand that. And one of the great things about the task force is that, I mean, we're not monolithic. We don't always agree. We don't have, and we'll have some challenging conversations, but we're not trying to, we never try to hurt each other's feelings, right? And so at times, if a white partner will suggest something and we say, you know what, that's just, perpetuating a racist ideology and stuff like that, and, we ain't doing none of that. Don't start crying and get, whatever, and understand it's just because we got work to do. And sometimes it can be kind of, this is hard. This is really hard, right? And it's not a place for really the meek and the mild, right? But we're, our team, we all operate in love, but we can't afford to center the feelings of white people in the midst of our work. It's just, it's too heavy of a burden. That answer your question? Okay. And we welcome everybody. I think that's the power of what we're trying to do, right? But we got to stay focused on what we're trying to accomplish. The last slide, Nancy, the last slide was kind of broad intentionally, because I only had 50 minutes, but each one of those 7 things to look at, okay, when we say, for example, creating, bringing every African-American child up to a grade level, right? Now, there's all kinds of things that are part in order to get that. So you unpack that, right? So, right. And so just kind of, so those are kind of places we want to get to, okay, right? And then we got to spend the time, right, to figure out, okay, if we wanted to, I think Black children in Buffalo Public Schools are like 3 or 4 grade levels behind right now. I think that's what it is. So what would it take to get those children up to where they're supposed to be? What would you have to do inside the system in order to make it happen? What do you have to do inside that classroom? And then what do you have to do inside the environment in which that child is living? And I believe, the people who work for me understand, I believe in making lists, right? And for the mathematicians on there, we talk about this a lot, and we're in the process of kind of building a model, right? And for those of you who took algebra and stuff like that, I hated it. But one of the biggest frustrations of that, right, is that if you just mess up one thing on that formula, right? If something's supposed to be positive and it's a negative, or if something's supposed to be to the 3rd power and you make it to the 2nd power and all that, what does that do? It completely messes up the outcome, right? And so what we have to do is we have to be very strategic and detailed to understand, if we say we want to get Black children up to the same reading levels and mathematic levels as white children in Clarence, if that's what we want to do, and that's what we need to do, that's what we should do, right? Then what will it take? and we cannot eliminate something, right? Because we're fearful that, you know what I mean? Because that one thing that you eliminate may be that determining factor, maybe that negative that should have been a positive that screws up the whole outcome. So take the time to really, that's why I really want us to take an intellectual approach to this, right? A social science, right? Not just focus on the social, but focus on the social science. And then trying to really be bold and saying, okay, this is what it, if we say we're about the, but if we don't do that, we should stop talking about health equity. Just stop. Because you're not serious about getting to where, you know, you're just saying it now because you think, you know, the Robert Wood Johnson is going to give you some money or something. But to really say, let's figure out a way in which we can solve these problems.
Thank you. I
Listen,
mean,
go ahead, Nancy.
yeah, no, I think that, you know, I mean, it's a wonderfully comprehensive agenda. And I share your frustration about foundations that don't want to, you know, solve problem solving. But I guess I'm trying to understand the work the Buffalo Center for Health Equity is trying to do, and being a think tank, really an action think tank, to plan out what are the problem solving actions that need to take place in this particular piece, and this other piece, and this other piece, because it does seem to me that if there's an action plan there of sorts, then we're in a better position to really advocate with funders. And they're not going to fund this think tank piece probably, or at least that they haven't been as willing to do that. And that's where you're trying to go right now, is to get those plans driven by science, because the last thing that I would ever even assume that I was qualified to do was to say what those action pieces should be. I mean, in other words, and I'm not going to be coming in saying, oh, here's all the things I, as a white person, think, you know, as a social scientist, white person, should be done here. I really feel like it needs to be driven by the community of people who need to benefit from this. But I also think that, you know, those of us who know some social science about some of these things can assist in that process. And then when the action part, when we have something that says this is the plan, and it has to be this community plan, then that's where the pressure politically needs to be brought to get funders actually interested in funding this, in whoever's going to be taking those problem solving steps. And again, that has to be driven by groups of people who really have the credibility to do it, not by our standard service system that we've had, you know, serving lots of white people in the community, or serving Black communities, but not in the way that they needed to be served. And I think, you know, if we don't challenge those assumptions, so I'm just trying to figure out, I'm, you know, this is not necessarily my area of research, but how can I help politically, strategically in that process? But also, I don't want to get in the way. I don't want to be one of these people who's like, oh, this is why I'm interested in this issue. It's like, you know, the problem's there. I don't need convincing. I just need some sense of how to focus, help, push, and make that happen.
Yeah, I mean, it's really about relationship building too, right? It's about really getting, like, you look at, every time I drive by the Albright Knox Gallery, right? And you see that's a testimony to what happens when people of influence make up their mind, they want to do something.
Right.
And I ain't mad at you. I ain't mad at folks for that. It's going to be great. Right? It's gonna be great, right? But they just made up their mind, that's what we're gonna do, right? And they figured it out. What do we got to do in order to make this happen, right? And so it's that same kind of an approach, right, around the health equity, you know, putting at the end of this is where we want to get to, and what do we need to do, and to develop a partnership with the Black community, not a paternalistic relationship, as someone mentioned in the chat, but a true partnership. We have the Buffalo Center for Health Equity have gotten a 5-year commitment from Highmark to support our work. But I was very clear with them that this is a partnership, right? This is not a charitable type of thing, whatever. But more important than the money but the money is important, is your willingness as a corporation, right, to partner with us in this work. And there's a lot of moral challenges with partnering with a health insurance company. I get all that stuff, right? But you got to use the resources that are available to solve the problems that are before you, right? And it's a new approach, and it's going to take us a minute to kind of see our way through. We're going to make some mistakes, but if we stay focused on the outcome, right, I think we'll get there. It's generational work. I mean, for interest of time, there's a list of accomplishments that we have, but I didn't think you wanted to hear all that today. But but we got a track record of getting a couple things done.
Thank you.
Uh-huh. Well, I thank you. I know we were supposed to go to 1:30, so thank you.
Yes. So in the interest of time, I don't want to keep anybody too much longer. I just wanted to say a quick thank you to Pastor Nicholas. I really appreciate you being here with us, sharing not only your knowledge with us and your experiences, but also your passion. It's very much appreciated. I thank everybody else in attendance for being so respectful and attentive, and also your thoughtful questions. Just very quickly before we close out, I want to remind everyone that we have 2 racial justice coordinating committee meetings on March 1st. There will be one at noon and one at 6 p.m. You can choose which one you'd like to attend if you have any ideas about what we need to do. And then also our next speaker series will be on April 10th with Dr. Autumn Blackdeer. That will also be on Zoom at 12:30.
Thank you.
Thank you,
Thank you
everyone.
so much. Have a great day.
You as well.